So I'm going to speak today about some of the background about PCSK9 inhibitors and leading up to their clinical use for prevention of cardiovascular disease. These are my disclosures. So I'm going to start with my key messages overall in this talk, which is that there is really abundant evidence that lower LDL is associated with lower cardiovascular risk, and that comes from many different sources, and I'm going to show you some of that. And then that there's a pretty elegant story connecting genetics and LDL biology that support the possibility of LDL lowering with PCSK9 inhibition as a novel way to think about reducing cardiovascular risk. So as a vascular medicine specialist, I really think one of the key points over the last few years is the increasing evidence about how high risk our patients with polyvascular disease are, and that many of our patients that we see that we're treating for coronary artery disease have concomitant peripheral artery disease or cerebrovascular disease, and these overlap patients have the highest risk. And this is just a little bit of data of that from the Euclid trial, where you can see that the higher lines are disease in more territories. These are all patients with underlying peripheral artery disease. And that when you get to the concomitant of all three diseases, their 3-year event rate is 1 in 5 patients. So potentially identifying our highest risk groups. Another really high-risk group are these patients with familial hypercholesterolemia. So this is a couple of different sources of data looking at those who have FH, defined as just an LDL greater than 190. And a couple points here. One is that if you look at their lifetime cardiovascular risk, those patients who haven't had clinical events but do have very high LDLs have an extremely high risk that's very similar even to those who've had prior clinical events. So their primary prevention is really more like secondary prevention. And then in both men and women, shown on the right, you can see that even at young ages, they have a high rate of a cardiovascular event. So it's really a premature development of atherosclerosis phenotype. So going back to the biology of atherothrombosis, it's really LDL here as one of the key initiating steps. We think about many different risk factors that we're intervening in our patients, but one of the triggers for the development of plaque is this LDL that, along with inflammation, infiltrates the wall of the blood vessel and leads to plaque formation. And so lowering LDL, the concept would be that you're taking away this initiating factor that may then really have a more primary prevention effect. So what's the data about LDL lowering? Because I think there was this whole controversy over a number of years. Is it LDL itself, or is it how we're getting the LDL lower in the specific drugs? But I think really now the evidence from a number of different sources is that it's the LDL lowering. So this is a meta-analysis from Mark Sabatine and colleagues. This is the most recent one, meta-analysis from 2016, including many of the more recent outcomes trials. And the point here is that when you look at the difference, so the degree of LDL lowering and then the benefit you're getting in terms of reducing cardiovascular events, it's a fairly linear association regardless of how you got there. So the more LDL lowering, the greater lowering of events. And there's not that many of these points that come off of that line, potentially the PCSK9 maybe, and you'll see some of the clinical data and other people's talks about this, and maybe the CETP inhibitors came off the line in an adverse way to the bottom. Maybe they had off-target effects that weren't just about LDL lowering, but in general, you see that most of these trials are on the line. And then interestingly, when you look here, so in the yellow, you see the secondary prevention, and then the black and below, you see the primary prevention. Of course, those primary prevention trials, the rates of events are going to be lower. But if you look at it, even in the secondary prevention and the intervention groups, which are all the clear, as you get LDL levels that are quite low, you start to approach the primary prevention event rates as the LDL gets low. So moving on to ways that you might get LDL lowering or the biology of this. And the story really about the PCSK9 is a very nice biological story. It really is a classical genetic story. We live in the era of GWAS, but this is really old-fashioned monogenetic genetics that have been around for a long time. And there were individuals in France originally who were found to have these gain-of-function mutations in PCSK9 and had a familial hypercholesterolemia phenotype and adverse event rates that was different than they did not have alterations in LDL receptors, or the more classic etiology for familial hypercholesterolemia. And then at the same time, it was found that there were individuals in cohort studies who were found to have extremely low LDL. And these individuals were actually it was enriched in African American populations, and there were specific genetic mutations. These are, again, were heterozygous, although there are homozygous individuals, and they had very low LDLs and had a very reduced rate of having coronary artery disease. So how does PCSK9 work? I like this graph because it doesn't have the liver. I don't know, whenever there's lipids and lots of livers and cycling, I feel like I get lost. But this is really just the simple biology of what happens to LDL. So the idea here is, we've known for many years that LDL receptor is responsible for bringing LDL out of the circulation and into the cell. And that's illustrated here. And then once the LDL receptor releases LDL into the cell, it's recycled back out to the surface, and it can, again, do that process. And so the more LDL receptor functioning there, the more that the LDL you bring out of the circulation into the cell. But it turns out that there's also this other process that goes on with PCSK9. So you can have some of these circulating LDLs that have PCSK9 attached to them. When they bind to the LDL receptor and come into the cell, the LDL receptor in this case actually gets put into the lysosome and broken down. So there's not recycling. So effectively, you lose that LDL receptor when it's been bound to PCSK9, and therefore you have less overall LDL receptor and higher LDL levels. So if you have loss of function of the PCSK9, then you enhance your LDL receptor recycling and lower LDL levels. And so if there was a way to pharmacologically inhibit the PCSK9, then you would have a similar effect. I'll just point out, so that's all about what happens with PCSK9 in the circulation, and most of the PCSK9 is in the circulation, but it's actually also manufactured by a number of different cell types in plaques or in the vessel wall, and I think the biology of that is a little bit less clear. But potentially the PCSK9 in the vessel wall also could have some biological effects related to uptake of cholesterol into macrophages and promoting foam cell formation, which may be relevant in terms of the ways that we think about inhibiting PCSK9. But that's, I think, a less developed story. So what does the genetic evidence tell us about the PCSK9 and LDL lowering and cardiovascular risk? And that is to say, above and beyond those individuals that were used to identify PCSK9, those individuals who have very low levels of activity of PCSK9. So this is data from hundreds of thousands of individuals and looking at a genetic risk score of modifications in either PCSK9 or HMG-CoA receptor reductase, which is, of course, the targets for statins. And you can see that essentially if the genetic risk score lowers the LDL by a certain amount, you get an equivalent lowering of cardiovascular risk, whether you get there through PCSK9 alterations or whether you get there by HMG-CoA receptor alterations. Regardless, it's really about the amount of LDL lowering that you get that corresponds to the amount of cardiovascular risk reduction. I did just put on the genetic evidence actually supports this concept that potentially there's some enhancement of the risk for diabetes that goes in the other way in terms of these, as you get LDL lowering, your risk for diabetes potentially might be increased, although remember that most of the risk associated with diabetes is cardiovascular event rate, so maybe I'm talking from a cardiologist and not an endocrinologist perspectives, but ultimately the clinical events for these patients are largely interfere. But the other thing that I'll just say about this is when you think about in terms of the overall net benefit of these genetic changes, it's probably related all to the LDL, not to really off-target effects. So maybe I'll just skip this to just talk a little bit about the overall, starting to think about what's the clinical evidence now other than the genetic evidence with PCSK9 inhibitors. So thinking about how it might inhibit it. And so there are no small molecule inhibitors. These are antibody-based inhibitors. And looking at a trial, this is the Glagov trial, which was looking at plaque volume. So looking at clinical outcomes, but looking at a biological intermediate. So you can see that those individuals who were on a PCSK9 inhibitor, evolocumab, had a dramatic lowering in the LDL, and that corresponded to a decrease in plaque volume based on IVUS. And again, the extent of LDL lowering here corresponded to the change in plaque volume. Interestingly, when you look at other plaque characteristics, so again, this red line is this same line, but looking here at calcification seemed to go the other way. So they don't all correspond. It didn't seem like actual histology of the plaque added that much information other than just looking at the plaque volume changes. So to summarize really some of this pre-event data, LDL can be lowered in many different ways, but we have a lot of new tools to be able to lower LDL to really dramatically low levels. And the genetic data and imaging suggests there's a direct association between LDL lowering and benefit. And I think that moves us into the question of looking at cost and other factors, which are the patients that are going to derive the greatest benefit from our new tools for intense LDL lowering. I'll finish there. Thank you.
Stay there for a second. Yeah, just stay there for a second. We have some time for a discussion since it's an interesting and exciting physiology. Any questions from the audience so far? Yes, sir.
Thank you for excellent presentations. I'm a vascular surgeon by trade, and what you just got from the Glagov immediately trigger asymptomatic carotid occlusive disease. And can we regress the plaque to a point of non-critical stenosis? I'm sure it's all cardiology related, what you just presented, but any thoughts or ideas in terms of volume reduction? We're talking about a significant volume reduction to a point to be a non-ACAS candidate and treat asymptomatic disease medically?
Yeah, well, there are a lot of questions bundled in that question. So I think, one question is, our patients always have the ultimate idea. They want us to get rid of their plaques, right? That's what, I don't think we're completely there yet. Ultimately, I suppose that's one possibility. I'm not sure we're at the point where we can reduce flow limiting lesions to non-flow limiting lesions. But the bigger picture, right, is what are the active plaques, especially you're talking about carotid disease. Can we take plaques that have potential for instability to plaques that are going to be stable over time? And ultimately, I suspect that when you look at LDL lowering and its clinical benefit, it really isn't about stenosis progression as much as it is about stabilization of plaques.
Yeah, I think that's really well put. As part of the Glagov trial, and recall with the high dose statins, you might reduce your plaque volume. The original trials of the Saturn trial suggested maybe a 2% volume reduction, which is minuscule. You're never going to turn that 70% lesion into a 40% lesion. And so I think I tell my patients to be realistic and say, this grew out of your body for the past 70 years. We're not going to have liquid Drano to be able to take it apart, but we can stabilize the plaque, reduce the number of clinical events, and that may be the most important thing. Other questions? We had another question up there. I had one question. There's been concern about the extent of LDL lowering. Is there a lower limit to how low we can go, and is there a danger to that?
Yeah. Patients worry a lot about this. There's two pieces. One is looking, I think, at side effects in individual trials, which I think are worth looking at. And the other is, does the overall genetic evidence, which I think for LDL lowering is fairly robust. We have so much clinical data about this. And I think if you look at that evidence, the answer is really no, that the natural levels for our LDL levels probably are in that 30 to 40 range. And so we're not really getting to out of the physiologic range for what's needed for LDL. And there doesn't seem to be, other than this question of, I did show you that diabetes, but in terms of a lot of the other things that our patients worry about dementia or cancer, there doesn't seem to be any evidence that there's an increase in risk.
Good morning, great session. My question was, I understood from your presentation that is the reduction in the LDL and not really how you do it. So my question to you was that we learned all those things about pleiotropic effects of statins and the anti-inflammatory effects. Are you suggesting that those are not as important? That question number one. And two, are there any other, I understood that there are not, but just want to confirm, are there any pleiotropic effects with the PCSK9 inhibitors?
Yeah, so that's a great question. And I looked a lot at this, and I was going to put some slides because there has been some work looking, for example, at circulating PCSK9 levels, and does that associate with endothelial function, one of the areas of my research. And I ended up not putting any of it there because for two reasons. One is I think it's been really all over the map in terms of the associations with other sort of preclinical, and does say PCSK9 levels, do they associate with events independently of LDL? And the answer seems to be no. And I think that, to me, if you look at that genetic piece, I really do think it probably is not going to be a pleiotropic effect. Now, that doesn't mean that I didn't really go into the details of this issue about what happens to the PCSK9 levels in the wall. I sort of alluded to that, and it may be that if you have antibody-mediated lowering, you're really just lowering the circulating levels, and there are going to be some siRNA-based therapeutics that will reduce PCSK9 in the plaque as well as in circulation. So to me, that's a little different. It may be that you can get more of a robust effect if you lower the PCSK9 levels everywhere in terms of its effect on LDL biology in multiple different locations. But to me, that's different than a non-LDL based. And I think it's probably all LDL based from the evidence.
Great. Thank you very much.